Welcome back to The Deep Dive. Today, we are putting ourselves squarely in the position of senior faculty, guiding a dedicated MD anesthesiology student that's you through one of the most foundational yet frequently misunderstood topics on the exam board, nitrous oxide, or N-Euro. We know you are prepping for those high-stakes Gujarat University exams, and N-Euro, despite its long history, remains a high-yield favorite.
It absolutely does. And N-Euro is, deceptively simple. It's been in use for centuries, but the detailed structure of its physical properties, its kinetics, and particularly its toxicity profile, that's where the examiners really test your depth of understanding.
Okay.
So our goal isn't just to summarize the facts, it's to structure them perfectly for a comprehensive 20-mark answer. We're aiming for precision, mechanism, and clinical relevance across the board.
Let's start exactly where the examiners do then, the introduction. Define nitrous oxide and position it within the landscape of inhalational agents. Keep it crisp, factual, and high impact.
Okay, so we begin by defining nitrous oxide as a simple, colorless, inorganic gas anaero with a molecular weight of 44. It's often referred to by its historical moniker, laughing gas.
Right.
For classification, it is the classic example of a weak inhalational anesthetic agent. And the most crucial introductory point is its potency, which is quantified by its minimum alveolar concentration, or MAC. That stands at approximately 105%.
That 105% figure is the immediate clinical and exam differentiator. Why is that?
Because it tells the examiner instantly that NRO cannot produce surgical anesthesia or 1 MAC at standard atmospheric pressure. The maximum you can give is 100%.
Of course.
So this confines its role almost exclusively to being an adjuvant or a carrier gas for more potent volatile agents. You have to use terms like weak and adjuvant right at the start.
And what about its unique physical state? It's often grouped with the volatile agents, but it's fundamentally different, isn't it?
Yes, that's another key distinction. N-Euro is a gas at standard room temperature and pressure. It's not like the modern volatile agents, sevoflurane, isoflurane, desflurane, which are all liquids stored as vapors.
So that difference impacts everything.
Everything, from cylinder storage right through to the delivery mechanisms.
But I think function is perhaps the biggest separator. Beyond its weakness, what makes N-Euro functionally unique compared to, say, sevoflurane?
It is its powerful analgesic effect at subanesthetic concentrations. This is a characteristic that, well, the modern volatile agents just don't really have.
It's a painkiller.
A very effective one. A concentration of just 20% N-Euro is potent enough to produce analgesia that's roughly equivalent to an effective dose of conventional morphine. Volatile agents primarily deliver amnesia and immobility, the MAC effect, while N-Euro gives us robust pain relief alongside sedation.
Okay, knowing the examiner's mind, if N-Euro is the topic, what are the inevitable question patterns you have to be prepared for?
You should prepare for an essay-style question, a full 20-mark challenge that demands a structured overview of its pharmacology. Or maybe a more controversial angle like, discuss the current status of nitrous oxide in modern anesthesia. And that requires you to present a balanced view, weighing its advantages against the severe toxicity and, of course, the environmental concerns.
And within that big essay, what are the mandatory subtopics you absolutely cannot miss?
You must master the physical properties, the critical temperature, and the blood gas coefficient. You have to be able to articulate the concentration and second gas effects flawlessly. And absolutely critical for the toxicity marks, you need a detailed mechanistic explanation of vitamin B toxicity.
The specific enzyme.
The specific enzyme inhibited, yes, and the physics of the expansion of closed air-filled spaces. If you miss any of those key mechanisms, you will lose significant marks.
Okay, let's unpack those precise chemical and physical properties. This is where the foundation for all the clinical effects lies, and precision is paramount.
The basics first. Colorless, sweet-smelling, non-irritant, inorganic gas, molecular weight of 44. Regarding safety, you must highlight that N-Euro is non-explosive and non-flammable, which historically was a huge advantage over highly explosive agents like ether.
But,
and this is a big but, like oxygen, it is a potent supporter of combustion. So if a fire starts in the operating room, the presence of N-Euro will dramatically accelerate the burn rate. That's a really important safety distinction.
Got it.
We also note its chemical stability. It remains unreactive in the presence of soda lime, unlike some of the older VAs.
Now for the non-negotiable quantitative data, starting with the property that dictates its storage, the critical temperature.
Right. The critical temperature is 36.5 degrees Celsius. This is the highest temperature at which the gas can be converted to a liquid just by applying pressure. Below this temperature, it exists in two phases, liquid N-Euro at the bottom and gaseous N-Euro vapor on top, all inside that French blue cylinder.
And what's the immediate clinical implication of that 36.5-degree critical temperature, especially in a tropical environment like Gujarat?
Well, since 36.5 degrees is above typical room temperature, that liquid vapor mixture ensures that the pressure inside the cylinder stays constant, specifically at 4,400 kPa, or about 745 psi, for as long as any liquid remains.
So the pressure is just the saturated vapor pressure.
Exactly. But in a tropical climate, if the ambient temperature goes above 36.5 degrees, the N-Euro will exist entirely as a gas, and then the pressure will fall proportionally to the contents, just like an oxygen cylinder.
And that constant pressure leads directly to the classic exam trap.
How do you know how much is left?
Exactly. You must emphasize that because the pressure gauge remains constant until the liquid is fully gone, the only accurate way to determine the amount of N-Euro left in the cylinder is by weighing it.
Not by looking at the gauge. Never. This is a stark contrast to oxygen, where pressure loss is linear. Failure to weigh is a potentially dangerous error in practice, and it's a definitive mark loser in the exam.
Let's talk about the filling ratio. This is a direct safety measure tied to this liquid storage.
Yes. The cylinder must never be completely filled with liquid. We use a filling ratio, the ratio of the weight of liquid N-Euro to the weight of water needed to fill the cylinder. It's typically 0.75 in temperate climates like the UK.
And in hotter climates.
In hotter regions like India, thermal expansion demands a lower ratio, usually 0.67. This ensures that if the cylinder heats up, the liquid expansion doesn't increase the pressure beyond the safety limits and cause a catastrophic rupture.
Now, the properties that govern speed, the solubility coefficients. Let's start with the blood gas partition coefficient.
This is probably the most important kinetic number for you to remember, 0.46 or 0.47. It's an exceptionally low coefficient, which means N-Euro is highly insoluble in blood.
And that's the key.
That is the bedrock of its entire pharmacokinetic profile. It rapidly dissolves and rapidly leaves the blood, which leads to a very, very rapid onset and offset. We often use halothane with a coefficient of 2.5 as the classic contrast to highlight just how insoluble N-Euro is.
And the oil gas partition coefficient, what does a value of 1.4 tell us?
The oil gas of 1.4 indicates low lipophilicity, so low fat solubility. This means N-Euro doesn't build up significantly in peripheral fat or other fatty tissues, which really helps with its rapid washout.
Another big contrast.
Of a huge contrast. Halothane's oil gas coefficient is 224. This massive difference explains why recovery from a long N-Euro case is swift, while recovery from a long halothane case was notoriously slow.
Okay, and we must finalize this section by confirming the MSC.
A MACI is 104 or 105%. This figure was historically established using hyperbaric chambers where volunteers were subjected to pressures around 2 atmospheres, allowing the required MSC concentration to be safely given.
So again, it confirms its role.
It confirms, once again, that N-Euro is a weak agent that serves strictly as an adjuvant at sea level.
Okay, moving from physics to pharmacology. The mechanism of action is crucial because N-Euro really breaks the mold established by the modern volatile agents. Where does it primarily exert its effects in the CNS?
Its primary molecular target for its hypnotic and dissociative effects is the N-methyl-D aspartate receptor, the NMDA receptor.
Okay.
N-Euro acts as a non-competitive antagonist at this receptor. And this is a fundamental difference from pretty much all the halogenated volatile agents whose main mechanism is potentiating the inhibitory effects of GABA-A receptors.
So if N-Euro is an NMDA antagonist, that immediately puts it in the same mechanistic class as ketamine. Does that have direct clinical parallels?
It does, conceptually. Like ketamine, N-Euro produces a state that is more like analgesia and sedation than the profound CNS depression and amnesia you get with high-dose volatile agents.
And what about neuromonitoring? That's a big deal.
It is, and examiners love this question. NMDA antagonists, including N-Euro, do not suppress the cortical EEG or BIS indices as readily as GABA agonists do. This means using N-Euro can lead to falsely high BIS numbers, requiring you to rely more on traditional signs of depth.
Or turn down the N-Euro.
Or turn it down, exactly, if you're relying on BIS alone, to avoid giving an overly deep volatile anesthetic dose.
Okay, now let's isolate its famous analgesic action. What's the mechanism behind that powerful pain relief, even at low concentrations?
The analgesic mechanism is distinct from its hypnotic one. It's attributed to the stimulation of opioid receptors, specifically Mu and kappa mediated by the central release of endogenous opioid peptides, like proenkephalin.
So it's a very potent pathway.
Very potent. We'll
Yeah.
say it again. 20% N-Euro delivers analgesia equivalent to a conventional therapeutic dose of morphine. This confirms its powerful role in acute pain management.
So we have a dual action agent, NMDA antagonism for sedation and opioid stimulation for analgesia. How does this make it synergize with, yet differ from, the volatile agents?
Well, the difference is in the primary clinical endpoints. Volatile agents primarily cause immobility, the MS effect, and amnesia. MS provides analgesia and sedation.
But their MSCs are additive.
Remarkably, yes. Despite these different molecular pathways, their MAs are additive. A core exam concept is that if you use half a mg of NO, so about 53%, and half a mg of sevoflurane, about 1%, the resulting effect is 1 MA, surgical depth.
Which is why it's a MSC-sparing agent.
Exactly. It allows us to achieve deep anesthesia while minimizing the dose-dependent side effects of the more potent volatile agent.
The kinetics of N-Euro are dominated by that one factor, its ultra-low solubility. Let's trace the journey from the machine to the brain and back.
That low blood gas partition coefficient, the 0.47, drives extremely rapid uptake and distribution into the blood. And unlike highly soluble agents where uptake is critically dependent on blood flow.
With N-Euro, it's flow-independent.
Largely flow-independent, yes. This is important. Even in patients with low cardiac output, the low solubility prevents a dangerous, rapid rise in the alveolar concentration towards the inspired concentration because the blood just has very little capacity to hold the gas.
This rapid uptake, when you're giving high concentrations, creates the first major kinetic phenomenon, the concentration effect. Can you explain that mechanism thoroughly?
Okay. The concentration effect is the accelerated rate of rise of the alveolar concentration of NO when it's given in high concentrations, typically 60% or more. The mechanism is a physical volumetric one.
Right.
When you deliver, say, 70% NOO, the massive concentration gradient drives an enormous volume of gas. Initially, uptake can exceed 1 liter per minute from the alveoli into the blood. This huge volume absorption effectively shrinks the total gas volume left in the alveoli.
And if the volume of the alveolus shrinks, what happens to the gases that are left behind?
They get concentrated. The remaining gases, including the NO that hasn't crossed yet and any co-administered gases, they become physically concentrated in that smaller volume. This increased partial pressure then drives the remaining NO into the blood even faster.
Which is why it's called the concentration effect?
Exactly. It accelerates its own uptake.
Yeah.
And it's only really significant for NRO because no other anesthetic is given in such high concentrations.
And now for the famous follow-up, the second gas effect. This is the accelerated uptake of another agent you give at the same time.
The second gas effect is really the clinical exploitation of the concentration effect. When that massive volume of NO rushes out of the alveoli, it concentrates any other gas present, the second gas, which might be sevoflurane, or, critically, oxygen.
So it concentrates the second gas?
It concentrates it, and on top of that, the rapid absorption creates a temporary subatmospheric pressure in the alveoli, which then augments the total flow of gas from the trachea into the lung. We call that augmentation of tracheal inflow.
So those two mechanisms combined, the concentration and the increased flow, what do they do for the clinician at the bedside?
They drastically speed up the induction time of the co-administered volatile agent. So if you induce with 70% N-Euro plus sevoflurane, the SIVO reaches its effective concentration much faster than if you used it in 70% nitrogen.
And there's a safety benefit, too.
Yes, and it's often overlooked. The second gas effect also ensures a higher alveolar oxygen partial pressure during the initial phase, a critical safety benefit during the vulnerable period of induction.
Finally, elimination. How does the same kinetic property that speeds induction dictate recovery?
The recovery is equally rapid. N-Euro has minimal metabolism. Less than 0.02% is broken down. The rest is eliminated rapidly and almost entirely through the lungs.
Which sounds great.
It is. It facilitates quick recovery, but it immediately introduces the greatest kinetic risk of N-Euro, diffusion hypoxia. We'll get into the mechanism of the Fink effect later, but that rapid elimination is the precondition for this dangerous postoperative event.
Let's move to the effects on major organ systems. The cardiovascular section is a favorite for examiners because it involves two completely opposing effects. What is the direct action of NO on the heart?
NO is, by itself, a direct myocardial depressant. In isolated heart preparations, it reduces contractility, stroke volume, and cardiac output, very similar to the baseline effect of most volatile agents.
But clinically, we rarely see profound cardiovascular depression with NO, so why is that?
This is due to a powerful secondary effect. NOO stimulates the sympathetic nervous system. This leads to an enhanced release of catecholamines, norepinephrine, and epinephrine, which then counteracts the direct myocardial depression.
So you get some vasoconstriction.
Mild peripheral vasoconstriction, yes.
So when these two opposing effects balance out, what is the net clinical result that you have to report in the exam?
At typical concentrations, up to 70%, the net clinical effect is usually remarkably stable hemodynamics. Blood pressure often remains minimal or only slightly reduced, and systemic vascular resistance is maintained. Cardiac output is often preserved or even modestly increased.
And what about arrhythmias?
Crucially, and unlike halothane, N-Euro does not sensitize the myocardium to circulating catecholamines, which makes it safer in patients with underlying ischemic disease.
Okay, turning to the respiratory system, how does N-Euro affect the mechanics and regulatory drives of breathing?
N-Euro typically results in a pattern of increased respiratory rate, or tachypnea, coupled with a corresponding decrease in tidal volume. The net effect on overall minute ventilation is often negligible, so resting PACO levels are generally well maintained.
But there's a high yield point here.
Yes, the high yield note is about regulatory suppression. N-Euro markedly depresses the hypoxic ventilatory drive. This is the vital mechanism mediated by the peripheral chemoreceptors in the carotid bodies that respond to low oxygen.
And that's a significant risk.
It's a huge risk. This suppression occurs even at concentrations far below EMA, highlighting a significant danger in patients who rely on this drive, like those with COPD.
Let's tackle the cerebral effects, which are critical for anyone practicing neuroanesthesia. Does N-Euro increase intracranial pressure?
When it's given as a sole agent, yes, NEO does cause cerebral vasodilation. This increases cerebral blood flow, or CBF, and unlike many VAs, it also causes a mild increase in cerebral oxygen consumption, CMRO.
So that increase in CBF can lead to a rise in ICP.
It can lead to a demonstrable, though usually mild, elevation in ICP.
That sounds like a clear contraindication in a patient with a brain tumor or compromised intracranial compliance. Is there a nuance here that changes the clinical decision?
Yes, and this nuance is vital for the exam. The adverse cerebral effects, the increased CBF and ICP, are greatly attenuated or even rendered minimal when NEO is combined with intravenous agents that are powerful cerebral vasoconstrictors.
Like propofol or opioids.
Exactly. Propofol or high-dose opioids. They essentially mitigate the NEO-induced vasodilation. However, the risk of N-Euro diffusing into surgically created air pockets remains an absolute contraindication in specific neurosurgical procedures.
Finally, the pulmonary circulation. Why must N-Euro be used cautiously in cardiac patients, especially those with pre-existing pulmonary hypertension?
NEO is known to cause a dose-dependent increase in pulmonary vascular resistance, PVR, and consequently right atrial pressure. This PVR increase is dangerous in patients who already have pulmonary hypertension or pre-existing right ventricular dysfunction.
It could precipitate right heart failure.
It can, absolutely. Furthermore, NEO causes a small but measurable reduction in hypoxic pulmonary vasoconstriction, or HPV.
Can you just quickly explain HPV? Why is impairing it clinically relevant?
Sure. HPV is the lung's natural protective mechanism. It constricts blood vessels in areas of the lung that are poorly ventilated to shun blood towards well-ventilated segments. It optimizes VQ matching.
So if N-Euro impairs that?
If N-Euro impairs HPV, even slightly, it means more blood flows through poorly ventilated areas. This increases the physiological right-to-left shunt, leading to poorer oxygenation. It's particularly relevant in delicate procedures like one-lung ventilation or in patients with severe lung disease.
Okay. Despite the environmental and toxicity risks we'll get into, N-Euro remains indispensable in several clinical settings. Let's outline its primary applications, starting with its role in balanced anesthesia.
Its role here is fundamental. N-Euro serves as a carrier gas and an essential adjuvant. By giving 60 to 70% N-Euro, we achieve a substantial M-axis sparing effect, reducing the required concentration of the volatile agent by up to 50%.
Which is a huge advantage.
It's highly advantageous because it lets us maintain anesthetic depth while significantly reducing the dose-dependent adverse effects of the VAs, particularly their effects on circulation and respiration. It's a classic strategy for hemodynamically stable maintenance.
The other major application is procedural pain management, where its rapid kinetics and analgesic potency really shine.
Exactly. N-Euro is a mainstay for acute analgesia, most notably delivered as Entonox. which is the premixed cylinder of 50/50 Neuro and Euro.
Right.
This mixture is highly effective for rapidly fluctuating acute pain. Think of labor analgesia studies confirm 50% in Euro provides better pain relief than conventional doses of pethidine. It's also invaluable for reducing anxiety and pain during minor procedures, dental work, and trauma management, like burn dressing changes.
What about its place in pediatric anesthesia? There are concerns about neurotoxicity in developing brains.
In pediatric practice, NO's rapid kinetics and, importantly, its odorlessness make it an excellent adjuvant for inhalational induction. We often start with NRO and oxygen before introducing sevoflurane to ensure a smoother, less alarming process for the child.
We see.
It's also very popular for procedural sedation and analgesia in pediatric radiology or dental clinics. While concerns about developmental neurotoxicity exist in very prolonged, high-concentration use, its established safety profile for short procedural use in older children remains strong.
So if an examiner asks for specific situations where NO is beneficial over other agents, how do we frame that answer?
Focus on 3 specific benefits. First, situations requiring rapid changes in anesthetic depth. If you need to lighten or deepen the plane quickly, NO's low solubility makes that possible.
Okay.
Second, when NAC sparing is essential to mitigate significant cardiorespiratory depression, for example, in a frail elderly patient. And third, NO use during general anesthesia for cesarean section has, in some large audits, been linked to a decreased incidence of awareness.
Let's consolidate those advantages. These are the positive bullet points needed to balance the complications section in a long essay.
Number 1 is its potent analgesic properties. The effectiveness of NaZO in achieving analgesia at sub-anesthetic concentrations, equivalent to opioids, gives it a functional advantage over all other VAs.
And speed is advantage number 2.
Rapid onset and offset. This is its defining kinetic characteristic, directly from its low blood-gas partition coefficient. This speed translates to safer, faster inductions and quicker recovery times.
The functional advantage in the operating theater?
The MSG pairing effect. By reducing the potent volatile agent requirement by up to 50%, we minimize the associated systemic side effects, allowing for better maintenance of circulatory and respiratory homeostasis.
And the practical and economic points.
Cost effectiveness. N-Euro is significantly cheaper to produce and administer than newer agents, making it economically attractive. And we must list its favorable hemodynamic profile. That internal balance between direct myocardial depression and sympathetic stimulation generally results in cardiac stability.
And we should also mention, it's vital to remember that NERO is the only commonly used inhalation agent that is non-triggering for malignant hyperthermia.
A massive safety advantage over all the halogenated VAs, absolutely.
Okay, this is the critical section. Accuracy and mechanistic detail will make the difference between a good answer and an excellent one. Let's start with the immediate kinetic risk upon emergence. Diffusion hypoxia, or the Fink effect. Explain the mechanism slowly and precisely.
Okay. Diffusion hypoxia is the rapid reduction in alveolar oxygen partial pressure that occurs specifically upon the cessation of N-Euro. The mechanism hinges on the massive solubility mismatch. Because N-Euro is so rapidly insoluble, when you switch off the gas, a large volume, we're talking several liters over the first few minutes of N-Euro, rapidly rushes, or effluxes, from the highly saturated blood back into the alveoli.
And why is that efflux dangerous?
That massive influx of N-Euro into the lung space transiently dilutes the volume of gas remaining in the alveolus. Specifically, it dilutes the concentrations of both the oxygen and the nitrogen present. This leads to a drop in the partial pressure of alveolar oxygen.
So if the patient is just breathing room air?
If the patient is left to breathe room air, which is only 21% oxygen, this rapid dilution can push the PaO below safe levels, resulting in clinical hypoxia.
The mandatory clinical intervention for prevention, which must be drilled into memory.
Administer 100% oxygen for a minimum of 5 to 10 minutes upon discontinuing N-Euro. This absolute rule is the examiner's required safety answer.
Okay, next. The most dangerous physics phenomenon of N-Euro. The expansion of closed air-filled spaces. This is based entirely on the differential solubility compared to nitrogen. Let's quantify that difference.
Right. N-Euro is incredibly soluble compared to the nitrogen that makes up most of the air. N-Euro has a blood-gas partition coefficient of 0.47, while nitrogen has one of only 0.014.
So NO is
It's approximately 30 to 34 times more soluble than nitrogen.
So if we introduce NRO into the patient and that patient has an air pocket somewhere containing nitrogen, what happens?
The N-arrow rushes from the blood into that closed nitrogen-filled space 30 to 34 times faster than the poorly soluble nitrogen can diffuse out. This rapid, overwhelming influx of N-arrow significantly increases the total number of gas molecules inside the space, leading to a rapid expansion of the volume or a dangerous increase in pressure.
Let's list the critical clinical sites the examiner expects.
1. Pneumothorax or pulmonary blebs. A small pneumothorax can rapidly double in size or become a life-threatening tension pneumothorax. 2. Bowel obstruction. Gas in the bowel can expand severely, leading to distension and compromising the diaphragm or circulation.
3. Middle ear.
Yes, N-arrow diffusion into the middle ear causes significant pressure increases, leading to pain, hearing loss, or even rupture of the tympanic membrane.
And in neurosurgery.
Intracranial air, or pneumocephalus. Following certain procedures, air pockets can remain. N-arrow diffusion here dramatically and dangerously increases intracranial pressure.
And the most critical scenario.
Intravascular air emboli. This is arguably the most critical. An air bubble, say from a central line, exposed to NEO can rapidly expand, transforming a small embolus into a massive critical obstruction in the coronary or cerebral circulation.
Okay, moving beyond the physical risks, NEO is linked to increased postoperative nausea and vomiting, or PONV.
Yes, NEO is associated with a reliably increased incidence of PONV, particularly in adults.
Yeah.
The exact mechanism is debated, but it's thought to relate to its effects on the CNS, including direct stimulation of the chemoreceptor trigger zone.
Which is why it's often avoided in high-risk patients.
Exactly. Standard PONV prophylaxis protocols often recommend minimizing or avoiding NRO entirely in those patients.
Now for the exam gold standard. The irreversible toxicity of NERO on vitamin B and the bone marrow. Explain the precise molecular mechanism step by step.
This needs extreme clarity. NEO toxicity involves a direct, dose, and time-dependent chemical reaction. The NERO molecule oxidizes the cobalt atom that's inside the vitamin B or cofactor.
And that oxidation renders the bis inactive.
Completely inactive.
What is the resulting clinical chain reaction?
Well, inactivated BO cannot function as the cofactor for the enzyme methionine synthetase. The irreversible inhibition of methionine synthetase halts a crucial step in single carbon metabolism.
And this enzyme is essential for two vital processes.
Yes. One, the conversion of homocysteine to methionine, which is essential for myelin precursor synthesis. And two, the synthesis of thymidine and tetrahydrofolate, which are essential components of DNA.
And the clinical consequences of halting DNA synthesis and myelin production.
The interference with DNA synthesis primarily affects rapidly dividing cells, so the red blood cell precursors. This leads to megaloblastic anemia or bone marrow depression.
And the nerve damage.
The interference with methionine synthesis leads to demyelination of peripheral nerves and the spinal cord, manifesting as peripheral neuropathy, specifically subacute combined degeneration of the spinal cord. And critically, these effects are noted after prolonged use, typically 40 minutes of continuous administration.
And the enzyme inhibition is irreversible.
It's irreversible until new enzyme is synthesized, which can take days.
What about the risks to pregnant patients?
Because it interferes with DNA synthesis, NERO is associated with teratogenicity and an increased risk of spontaneous miscarriage, particularly if used frequently or for prolonged periods during the first trimester.
And finally, what about occupational exposure for healthcare personnel?
Chronic low-level exposure in the OR due to inadequate scavenging poses the same long-term risk: peripheral neuropathy and bone marrow suppression. This is why we have strict adherence to scavenging and monitoring standards, like the UK's CO-SH reach regulation limit of 100 parts per million.
Given those severe risks, the list of contraindications is lengthy. Let's strictly delineate the absolute risks from the relative ones. What are the non-negotiable absolute contraindications?
The absolute contraindications are those where the consequence of volume expansion or a pressure rise is catastrophic.
So, number 1.
Any known pneumothorax or documented air emboli. 2, acute bowel obstruction. 3, recent intraocular gas injection. 4, neurosurgery involving known intracranial air pockets.
Middle ear surgery.
Yes, middle ear surgery like a tympanoplasty. Also post-cardiopulmonary bypass due to the critical risk of expanding small residual air bubbles. And finally, congenital heart disease with severe pulmonary hypertension because it can dangerously increase PVR.
That's the list driven by the solubility mismatch. Now, for the relative contraindications, which require more clinical judgment.
These are often time or concentration related. So prolonged cases, anything anticipated to last longer than 40 minutes, should prompt you to reconsider because the methionine synthetase inactivation.
Okay.
Also, significant respiratory compromise, patients with severe COPD or large bullae. The first trimester of pregnancy due to teratogenicity concerns, and often in neonates and preterm infants due to high baseline oxygen requirements.
The current status essay demands coverage of the environmental cost. This is probably the single strongest argument against NEER's routine use today.
It's a staggering environmental pollutant. It's classified as a potent global greenhouse gas. Its global warming potential, or GWP, is approximately 300 times that of carbon dioxide over a 100-year period.
300 times.
And on top of that, in-utero is also a potent ozone-depleting substance.
That GWP number is truly shocking. If a modern inhalational agent had this profile, it would never be approved. So why hasn't it been completely phased out?
That's a critical point to consider. The argument for keeping it relies on its clinical utility, its unique analgesic profile, its speed, and its cost-effectiveness, especially in low-resource settings. But its continued use is under enormous scrutiny.
Driving interest in alternatives.
Exactly, like xenon, which is environmentally inert but, prohibitively expensive. This whole environmental context necessitates strict compliance in the operating room.
Which brings us to scavenging. What are the requirements for controlling OR pollution and protecting staff?
Scavenging systems are mandatory in all operating rooms to actively remove waste anesthetic gases and reduce both environmental release and occupational exposure. We aim to keep occupational exposure well below set limits, like that 100 parts per million figure, specifically to mitigate the risk of chronic neurotoxicity in staff.
Let's put NEURO into context by comparing it directly with the modern halogenated volatile agents. The key differences of potency, speed, and safety.
The contrast is extreme. N-Euro is the weakest agent used in routine practice, with an MFI of 105%. Conversely, it's one of the fastest due to its ultra-low BG coefficient. The VAs are potent, but generally slower, with only desflurane approaching N-Ro speed.
What are the three crucial exam-oriented comparison points that would demonstrate a comprehensive understanding?
Okay, 1. NMDA additivity versus effect disparity. While MSD values are additive, you must emphasize that their organ system effects are not. Half a mass of N-Euro contributes minimally to myocardial depression. Half a MSD of halothane contributed heavily.
Point 2.
Kinetic uniqueness. N-Euro is the only common anesthetic agent that demonstrates the concentration and second gas effects because of the high volume of gas that has to be given.
And 3.
Safety profile contrast. N-Euro maintains cardiac stability through sympathetic tone, VAs cause dose-dependent vasodilation, and, again, N-Euro is non-triggering for malignant hyperthermia, a crucial advantage over all VAs.
That synthesis confirms NO's role as kinetically superior but pharmacodynamically complex. We're moving into the realm of the Viva, the sharp, fast questions designed to test deep knowledge. We've covered cylinder contents, but let's drill it one last time. Why must N-Euro cylinders be weighed, and what specific pressure readings should be ignored?
They must be weighed because, being stored as a liquid-vapor mixture, the pressure gauge provides a constant misleading reading of 4,400 kPa until all the liquid has been vaporized. The moment the pressure starts to drop, the cylinder is virtually empty.
A major safety concern in Entonox is related to cold storage, the risk of lamination, or the pointing effect. Describe the physical mechanism and the clinical danger.
Right. Entonox is the 50-50 mixture. This mixture has a pseudo-critical temperature of minus 5.5 degrees Celsius. If the cylinder is stored below this temperature, the NUO component liquefies. This phenomenon, lamination, causes the mixture to separate.
So you get layers.
You get layers. The less soluble oxygen remains gaseous, while the NUO liquefies at the bottom.
And the resulting danger if a nurse uses that cold, upright cylinder.
If the cylinder is used upright, the initial gas delivered is primarily the high-concentration oxygen layer. After this is exhausted, the liquid N-Euro vaporizes, potentially delivering a hypoxic mixture of nearly 100% N-Euro.
And the prevention.
Store the cylinders horizontally to maximize mixing, and crucially ensure the storage temperature remains above 5 degrees Celsius.
How does N-Euro affect skeletal muscle relaxation? This is a common point of confusion.
N-Euro causes minimal, almost negligible skeletal muscle relaxation. In fact, if you give it in high concentration or alongside high-dose opioids, it can actually contribute to or even induce skeletal muscle rigidity. It certainly does not enhance the action of muscle relaxants.
Let's provide the safe, examiner-approved answer for B, urotoxicity. What's the key phrase you have to use?
The key phrase is, NO causes the irreversible inactivation of the enzyme methionine synthetase by oxidizing the cobalt atom in vitamin B. You must specify that this effect is time-dependent and leads to both megaloblastic anemia and subacute degeneration of the spinal cord.
And for diffusion hypoxia?
The concise, safe answer is, diffusion hypoxia is the rapid drop in alveolar oxygen partial pressure caused by the mass efflux of NO from the blood into the alveoli upon cessation. It is prevented by administering 100% O for several minutes post-NO discontinuation.
For a 20-mark essay, structure is paramount. How do we advise the student to manage their time and maximize marks through presentation?
Think of it as mapping your knowledge onto the required categories. The structure itself is a signal of mastery. Always use clear labeled subheadings and extensive bullet points for lists like contraindications to make grading easy for the examiner.
Right.
The first 5 sections must establish the basic science: introduction, physical properties, mechanism, pharmacokinetics, and pharmacodynamics. That's your foundation.
And the second half then moves into the applied and safety science.
Exactly. Clinical uses, advantages, complications, that's a big one, contraindications, and environmental considerations. For time management, focus heavily on the sections with mechanistic detail, like complications and pharmacokinetics, as those are heavily weighted.
Any simple diagrams a student can quickly sketch to reinforce a point.
Yes, the concept of diffusion hypoxia is excellent for a quick sketch. Draw a simplified alveolus. Then a thick, large arrow labeled NO rushing out of the capillary into the alveolus, and contrast it with thin, small arrows for O and N entering the blood. It mentally reinforces the dilution.
And reiterate the absolute essential headings the examiner expects to see for a high score.
MC, blood gas coefficient, critical temperature and weighing, mechanism of action, both NMDA and opioid, concentration and second gas effects, closed air spaces, methionine synthetase inhibition, and diffusion hypoxia. If you cover those 8 points mechanistically, you've earned your marks.
Time for the final rapid-fire memory check. Let's distill this down into the core facts that must be memorized and recalled instantly during revision or in the viva.
Okay, here are the absolute high-yield points.
Right.
1. BG of 0.47 means ultra-fast kinetics.
Right.
2. MSE of 105% means weak, it's an adjuvant only. 3. Critical temp of 36.5 degrees necessitates weighing the cylinder. The pressure is a constant 4,400 kPa.
Got it.
4. Mechanism of action is dual, NMDA antagonist for sedation, opioid receptor stimulation for analgesia. 5. Kinetic effects. Only N-euro causes the concentration and second gas effects.
Check.
6. Cardiovascular profile. Sympathetic stimulation counteracts direct myocardial depression, but it increases PVR.
Okay.
7. Toxicity mechanism is time-dependent. Irreversible inhibition of methionine synthetase.
Key enzyme.
8. Toxicity consequence. Megaloblastic anemia and peripheral neuropathy. Effects start after about 40 minutes.
Right.
9. Closed space expansion. N-euro is 30 to 34 times more soluble than nitrogen. This leads to the absolute contraindications.
Yes.
Emergent safety. Mandatory 100% O for 5 minutes to prevent diffusion hypoxia.
11.
Malignant hyperthermia. N-euros is non-triggering.
And finally.
12. Environmental cost. Global warming potential is 300 times that of kilo-euros.
That is a phenomenal summary checklist. Now, provide a strong concluding paragraph suitable for the end of a long, well-argued essay.
A powerful conclusion should read something like this. In summary, nitrous oxide remains a pharmacologically unique agent, providing potent analgesia and valuable MSC-sparing effects derived from its exceptional kinetic profile and its distinct NMDA opioid mechanism of action. However, the use of NERO is governed by strict safety parameters. Its fundamental physical properties mandate meticulous vigilance regarding volume expansion in closed air spaces and the irreversible time-dependent risk of methionine synthetase inactivation. Given the increasing focus on resource allocation and environmental sustainability, NERO's continued utility must be balanced critically against its significant global warming potential, necessitating judicious patient selection and universal compliance with scavenging and emergence protocols.
That brings together utility, caution, and current relevance perfectly. And for you, the learner, as you solidify this knowledge for your exam, consider this final provocative thought that might arise in a viva. If an inexpensive, fast-onset alternative that provided equal MXC sparing but lacked the environmental GWP and the barotoxicity and ideal N-neuro replacement were available tomorrow, what clinical uses of N-neuro would still remain relevant? Ponder whether its analgesic profile is so unique that it would survive even complete replacement of its role in routine general anesthesia. That is all for this deep dive. We wish you the best in your exam preparation. Go crush it.